One of the advantages of being a director of an organization that's educational in nature, such as the Center for Podiatric Education, is that I have the opportunity to speak on topics that I feel are important to young practitioners. And one of the subjects I thought I'd briefly touch on is the subject of humility. Several years ago, I was surprised when the American College of Foot and Ankle Surgeons sent me my assignments for the annual scientific meeting, and one of the things they had asked was that we speak on, as panel members, humility. And we don't think much about that as podiatric physicians. You go through school, you go through a residency, and you're concerned about procedures and technology and techniques, and worried about your future making a living as a podiatric physician. And sometimes I think we forget about some of the wonderful and maybe not some of the wonderful things that can occur in our lives. When I received that assignment, I gave it quite a bit of thought, and I could think of good and I could think of not so good. The great educator William Osler noted that humility is a gift, and it is something that had to be learned as a physician in order to make us better physicians. It has been said that with humility we tend to speak with our patients, and without humility we tend to speak at our patients. And as an older practitioner, I could tell you that I believe humility does make one a better doctor. And more importantly, I think, or as importantly, is it gives us a perspective on the good that we can do. I see so much emphasis now on practice management and looking at patients as a source of income rather than forgetting the reason that we went into health care at all. And that reason was we want to help individuals. We don't place generation of income as our primary focus. It's assisting other people. So I wanted to relate 4 short stories, vignettes if you will, some good, some not so good, to show what humility is and what it can, the role it can play, I guess, in our practices. And it's derived from a source, meaning a clear perspective and respect for one's place in context, both good and bad. And I think this summarized it best, Albert Einstein, as to where ego and humility belong. So let me give you 3 vignettes. The first is a good one. In the mid-1980s, I was a residency director at Lindell Hospital, and I had performed a stay-peg procedure. And for those of you that are not familiar with it, this is a form of arthroresis with a polyethylene plug. And it was performed on a young man who had a very significant bilateral flat foot deformity and was constantly complaining of painful feet, was inactive, didn't do much physically, and was, according to his parents, picked on by other kids in school. His father was a rather large, physically fit gentleman who was rather disappointed in all of this. And I didn't think much of the procedure. I did a lot of arthroreses early on in my career. At first hand-carved arthroreses with Celastic, and then some of the work of Steve Smith with development of the the stay peg, which I always found to be a very reliable and helpful device in the right circumstances. But in any event, we did a stay peg procedure on this child, and he did well. His flat foot corrected remarkably well with the procedure, and his mother and father were extremely thankful for the surgery. He became physically active. He actually went on to star in sports in high school and went on to have a tremendous career. And according to his parents, that simple surgery that I had been trained to do changed this child's entire life. So much so that this was a procedure that was done in the mid-80s. I'm doing this dictation now in January 2018. I have received a Christmas card from that family thanking me for that procedure and the change it made in that child's life. I've received a Christmas card with an update on the child and, more importantly now, his children every year without fail since doing that surgery. So here was a relatively uncomplicated procedure, a subtalar joint arthroresis with a stay peg, that completely changed an individual's life for the better. And it shows you the power that you as a podiatric physician and surgeon can have in helping someone along, because I sometimes hear people say that what we do is trivial compared to an oncologist or a neurosurgeon, and there's no question that there are many that tackle on more complex and life-threatening diseases, no question about it. But I would never minimize the potential impact and influence that you can have on one's life. So it always makes me humble when I receive these cards every year, because it really wasn't much of a surgery, and it really wasn't much thought to do the procedure. It was what I thought a best option at the time, and yet this profession enabled me to do something tremendously good for another person. So we want to talk about humility. You see in front of you an x-ray of what's left of a first metatarsal, and this was the result of an avascular necrosis of a scarf procedure. Many years ago, I got to look at the scarf. I was a residency director. There was a lot of push on the scarf procedure out of the Chicago area. And while in many parts of the country the scarf procedure never really caught on, it was fairly popular and may still be in many parts of the country, and certainly in certain parts of the Midwest. So I took a look at the scarf procedure, and I started doing the scarf procedures, and I thought it was an okay procedure. And but I had one patient in particular, and we did this on a patient who was had a sedentary job. And these were the days when you actually admitted a patient to the hospital the night before surgery. They filled out a consent form. They got a whole battery of blood work. You would take them to the operating room, do your procedure. The patient would stay the night and go home the next day. So we're talking about quite a few years ago. And this particular patient underwent an uncomplicated scarf procedure, and I watched in horror as her great toe started to shrink. And I watched dissolution of her metatarsal. And at first I thought perhaps infection, ruled that out. And it became obvious that she had developed an avascular necrosis of the entire distal fragment of her scarf. I had never seen that before, nor have I seen that since. And I just watched with every month, every x-ray, shortening of her first ray. You could see the final end result. And I didn't know what else to do, so I I told her I had no ideas. I sent her to Chicago to see Chuck Gudis, who was the one who, with his resident, actually developed the scarf bunionectomy. And I paid her way to Chicago, and I said, you know, I want you to see the guy who has popularized this procedure. Perhaps he'd have some idea. And she went up to Chicago, saw Dr. Gudis, and came back. And I remember the conversation. She was sitting in the podiatry chair, and I was on my little stool, and I said, did you see Dr. Gudis? And she said, oh, yeah. She said, he's just like you. He has a bunch of residents and students running around, and they looked at my x-rays and moved my feet and took all kinds of measurements. And then he came in, and she went on, by the way, about what a good-looking guy he was. I think I started to get a little jealous after a point. And she said, well, he told me there was nothing that can be done, that you did nothing wrong, and that this is a very rare complication, but it did occur. And I think I caught a break because she had a sedentary job, because had she had a demanding job and had she been heavier, I think the lesser metatarsals certainly would have been at risk. And she looked at me and said, would you like to know why I'm not suing you for malpractice? Well, that kind of stopped me cold. And I said, yeah, I probably would like to know. And she said, well, first of all, she said, you did bunion surgery on both my daughters, which is true, and they both turned out well. She said, but you told me the night before surgery this could happen. She said, I remember laying in bed, and some of your residents came to me, and they had that consent form. And the consent form listed a whole bunch of complications, and I said to myself, don't sign this, because this is going to happen to you. You'll be the one that gets the complication. But I signed it, and I let you do the surgery. And she said, so I was warned, and I'm not happy, but you told me, and I was humbled by that. Not that I felt that anything had been done wrong, because I certainly didn't think a case of avascular necrosis was the result of anything I had done, but rather the patient in front of me who acknowledged an understanding that bad complications can occur, and that she did consent to the surgery, and that she wanted the surgery done. And I found that to be a humbling experience. Now, I actually still see her to this day periodically, as you'd imagine. She has some problems with calluses under her lesser metatarsal heads, but she's done actually reasonably well considering this short first metatarsal. Some years ago, Jack Schubert had published a paper looking at the effects on metatarsal first ray shortening and minimizing the significance of shortening in many cases, but I'm not sure he would have predicted that a patient with this degree of shortening would have done well. I never considered going back and doing any kind of bone transport or lengthening or grafting or anything like that, and she actually has done reasonably well, but her response to this conversation, or this complication, was humbling to me. I'd like to go on to a third example. This was actually a Lapidus procedure that, again, I had performed in the early 80s. This was before I think most people were really hooking into the Lapidus procedure. And it was a short girl, interesting woman, had several children that looked a little different, and had a huge intermetatarsal angle and just tremendous hypermobility of her first ray. And it was my opinion that nothing short of a Lapidus procedure would do the job. And to this day, I remember the operating room, the time of day, and the resident that I did this procedure with. So we went and did the Lapidus procedure, and her bones were just in terrible condition. And tried fixating it with screws, and they just wouldn't hold. And I tried a variety of screws, just wouldn't hold. Tried whatever we had. And no matter what I did, the bones were simply in terrible condition and would not hold the fixation. So I eventually used a ton of Steinmann pins and was satisfied that we'd probably get healing if we let this go long enough. This case is probably 25 years old, at least. So after the case, which went on for a long time, trying to figure out how to stabilize this, I went out to talk to the family, and they were standing there, and I had the resident off to the side, and I said, well, everything is okay, and she's going to do all right. But I said, you know, I had a lot of trouble fixating her bones, and they were very soft. And one of the family members said, you know, what do you mean soft? I said, oh, the bones were just horribly soft, and no matter what I used, it wouldn't hold. So I used a bunch of Steinmann pins, and I think they'll be adequate, but we're going to have to put her in a cast and keep her non-weight bearing longer than I had anticipated. And one of the family members said to me, well, why do you think her bones were soft? I said, you know, I really don't have any idea. And then the older male son said, gee, I wonder if it's that disease that we have. And I said, what disease? And he said, I don't know. It's some kind of disease with our bones, and we go over to the medical school every year, and they track our family. And I looked up, and I see that they all have blue-tinted sclera. And I said, do you have osteogenesis imperfecta? And the son says, yeah, that's what we have. So I saw my resident's head go down, probably in shame, but I was the one that realized I was the idiot, that I thought about the patient, and indeed she was short stature, and once I had the answer to the question, osteogenesis imperfecta tarda, I realized that I had just tried to do, or not tried, but did do a Lapidus on a patient with osteogenesis, and she worked out fine. She was in the office about 2 years ago for some orthotics, and I took a picture, and this is what she looked like years later, and I've treated several of her family members for fractures. I've learned a lot about osteogenesis imperfecta since that time, but it just goes to show you that all of us can be incredibly stupid at some point, and I certainly was incredibly stupid on that particular case. So I guess I felt that in that case I was definitely the village idiot. Lastly, I wanted to talk about, I think, the most humbling thing that's happened to me recently. I had an older gentleman, early 80s, who came in with an open transmetatarsal amputation of his foot, right foot, with his daughter, and he had terminal cancer. And he had an open TMA that had been performed elsewhere. All of his metatarsals were visible, and the tissues were fibrous, and they were just white and gray and nothing healthy at all looking. The bones were brownish in coloration, and he was there for an opinion because he wanted to die without his leg being amputated, and amputation had been recommended because he had this wide open TMA, and there was a fear of sepsis, and he was accepting of his terminal cancer. And whenever he would come to the office, he would talk about his 2 martinis every night. He always would make the point that he never had more than 2, and how his dog would sit on his lap with him all evening and all day, and how much he loved his dog. It's all he talked about, his 2 martinis and his dog. But he had an obsession, desire not to have his leg amputated. For some reason, as his daughter explained, it was extremely important for him not to lose this leg. Looking at this, it seemed to me that this was going to be an impossible situation. And he had been under the care of a vascular surgeon, and they felt that nothing else could be done. And he just did not want to go through the amputation, recognizing that he was going to die of his cancer. I sent him to an interventional cardiologist in St. Louis that I personally feel is as good as they come. And I said, is there any hope that we could do anything for this man? And he said, possibly. I sent him for a consult to set him up for a wound vac, and the nurses called me and said he's simply not a candidate for a wound vac. It's a dysvascular wound. It's all fibrous. There's just nothing there to heal. And I said, well, we're going to try to revascularize this fellow. And they said, no, we just can't agree to this. Well, the interventional cardiologist somehow succeeded in restoring some flow. And I started to follow this gentleman in the office, mostly monitoring him for sepsis. And much to my shock, with some debridement every 2 or 3 weeks, he started to pink up. And slowly, we're seeing more and more granulation tissue, and slowly he's looking healthier. So I took him to the OR, and I did a major debridement, and I couldn't believe it. And this went from an absolutely ischemic, non-viable TMA, and next thing I know, he's granulating, and it's getting redder and redder and beefier, and then he starts granulating over the bones. And we tacked on a wound vac. I debrided him every several weeks, not every week, certainly. Had his daughter monitor him for infection. And he came within the size of a dime of completely healing this wound. And then he died. And I got a letter from his daughter. I didn't know he died, telling me that he had died, and thanking me for allowing him to die with his leg on, because that was his wish. And he did indeed enjoy his final 2 martinis and had his dog with him when he passed. And I've kept that letter because, again, it showed something that we can do as podiatric physicians, that not all we do is trivial. And so here's an example of palliative care and something that changed somebody's life forever. And it was a humbling experience. So I wanted to give particularly the residents and students who might be listening to these tapes that we've been making something to think about. That it's more than doing a total ankle, and it's more than doing an IM nail, and it's more than reconstructing a Charcot joint, that sometimes you can do basic things as a podiatrist and bring tremendous care and love to people that you're going to attend to. And you want to step back sometime and think about why you first became a podiatrist, why you entered the healthcare professions at all. And maybe over time you'll develop a key component to being a doctor, as William Osler and Jay Katz in his textbook and many others have written, and that's humility. Because the gift of humility, as Dr. Osler noted, will help to make you a much better doctor. So I hope this has been helpful for some of you.